Solomon. Thank you all for having me. So today I'll be talking about the general experience of close to community CHW workers in Sierra Leone. So the aim of this study is to know what the experiences of close to community providers were. Essentially, we call them community health workers in Sierra Leone. CHWs are important cadre in the health workforce in Sierra Leone who bridge the gap between communities and formal health system. So their values have been demonstrated in each disease outbreak we have in our Sierra Leone context. So, but however, there are evidence gaps in terms of policy and practice and how those evidences have been adopted to be practiced, including their experiences. So why we did this study was to contribute to evidence on gender equitable approaches in supporting community health workers in fragile and set-prone settings, including Sierra Leone. So we selected two districts, Bond and Kenema. So Bond district is a hard-to-reach area with several riverine islands, and it was less affected by the Ebola outbreak with strong donor support compared to Kenema with less donor support and big towns and surrounding villages. So the methods we used were documentary review, which was followed by key informant interviews in the two study settings. So we interviewed 8 community leaders from each of the district, 4 from each district. We also did this based on gender differences, separated by gender. And then we did 4 focus group discussion, 2 in each district, 1 with each gender. So you can see there how we did a focus group discussion. So here we use the gender analysis framework to know the experiences of community health workers. We were expecting that their roles would be different, but to our surprise, we found that there was no much differences in their roles. So we can see here what motivated them to be engaged in this CHW work generally. So their regular roles: essential community-based, promotive and preventive care, nutritional screening and promotion, and referral services. So here the motivation first were desire to serve as healthcare workers. Most have been desiring to be health worker and linking the communities, since most people were dying, including women and children, from preventable causes. Maternal death is prominent in Sierra Leone, so these were some of the reasons for they being in the CHW work. So compounded with the COVID-19, their roles increased. Community mobilization for appropriate environmental, sanitation, and hygiene practices. They were also engaged in setting up their own emergency system and communication, community engagement about the awareness of COVID-19, since it was novel and confusing to everyone. So we can see here what their motivations were. Trust was less in communities, so they were there to build trust, raise awareness, and dispel myths around COVID-19. And also, since services were disrupted, they stepped in to reduce the issues of maternal and child death, and also positive impact conflict resolution. So as there was increase in gender-based violence due to lockdowns. Here we can see respect or morale. I know most might be wondering why. In certain communities, most CHW find that because they are engaged in the CHW work, they are highly respected by communities, though they are not handsomely rewarded for what they do, but the respect keeps them going in the work they do. So they also try to leverage on their influences on communities. So here, we had a gender implication. Sorry. So the gender implication, we found a gender implication here during COVID-19. So there were preferences for women community health workers in maternal health and psychosocial support. So picking out key points from their motivation, we can see quote from the positive impact there. And also to improve immunization coverage, which was disrupted due to the COVID-19 response. We can also see here a reduction of teenage pregnancy and maternal and child death. So I'm not going to go through all those quotes due to time limitation here. And then we talked about the work burden and their daily work life. Generally, before COVID-19, CHWs used to work 2 to 3 hours, but in the COVID-19 context, this was increased as they had to cover 10 to 15 households, especially quarantine homes. And it was quite difficult for them in accessing communities due to inaccessible roads and some in riverine areas. So the gender implication we found here was double burden of caregiving role of women's community health workers, plus the roles in taking care of their family. Nursing mothers had to wake up very early. There was a competing priorities between taking their kids to school and involving in their COVID-19 response activities. So we also found that stigma and mental health issues were a major issue among them. So we can find the stigmatization from community and family members. Here was a very, nerve-wracking one from a man CHW in Kenema district. So it was quite challenging for him with this experience. You can see that. A split between my family and friends. So I was a contact tracer. Some were totally scared of coming in contact with me. Only those who knew what my work was about could come close to me. So we also found that there was disruption in small businesses for CHW. So that also impacted their mental health since they were only involved in the COVID-19 response and could not continue their economic activities as usual. So physical abuse was quite prominent among male CHWs especially. We can also see from the quotes there. I can't read all of that. So support to CHWs were, so for family support, so most were motivated by their family members to continue doing what they do best. And psychosocial support was also provided by family members. So for community support, they were motivated and encouraged to work more, and some were encouraged by their spouses also. So psychosocial support by supervisors. So for the health system support, so CHWs were motivated to work more, but they did not earn the respect they deserve. Oh, so I think there was a glitch here. There might have been some technical issues here. So, but I can say that orally, for the health system support, there were support provided to them, but it did not serve them well. There were less support from the health systems. Community support, community leaders were providing them with security for those having difficulties in entering some communities to do their work. So the challenges they face here were, in terms of social norms and value, less audiences were given to female community health workers unless they have a male backup when they go to communities for their work. So CHWs were rendered powerless since most were under rentage. So accusations of prolonging the response effort and being accused of monetizing the whole response. So delayed payment of incentives and limited logistics and training were the challenges according to the categories here. So we can see from the code there also. So here, our reflections were there were less gender, traditional, and cultural consideration in the design of policies for CHWs. So gender parity is on paper, but in translation, this is not what is happening on the ground. So CHW incentive issues has been a long-standing problem that need to resolve. The human capital and institutional development is also not there. So strengthening the roles of community health workers at community level should also be considered. So these are recommendations. So we need to promote the work of CHW and integrate them during response, effective supervision for CHWs due to high attrition. So, and we should also increase and pay them timely their incentives, because we also find out CHWs were only given $15 a month, and that was not also given to them on time. That has to be accumulated for quarter. So these are the issues we need to address. I thank you all.
Thank you, Lansana.